All right. So the title of today's talk is Why Do Some People Hurt More Than Others? Obviously, this is a big topic, and I am not going to be able to cover everything out there in half an hour. I'm going to cover one aspect of this question, and hopefully we can get some good discussion out of this. I have to tell you, though, I actually really like public speaking. I'm probably one of the only people out there who goes to his bishop and says, you know, I have not been asked to give a talk in like a year. Can you please ask me? I'm probably about the only person who does that, and I was super excited to give this talk or this lesson. I've been preparing this for like years. I've wanted to give this discussion, and then on Friday, Amelia calls me and she says, we're going to record this. It's going to be up on the internet. And I was like, oh my gosh, people are going to be dissecting this for months and years afterward. I got so nervous this morning. This is not an exaggeration, you guys. I woke up this morning in a cold sweat at 4:30 because I had a nightmare that after this talk I was homeless, okay, because of this talk. This is the first time this has ever happened to me, so hopefully this turns out okay. So I am Dr. Joshua Hardman. I am a family medicine doctor, and the first thing you guys are going to notice up here is that, in quotes, BMD. I'm going to explain what that means here. About a year and a half ago, my son sent me a screenshot of a tweet. A friend of my son saw this tweet, sent it to my son because he recognized a picture of me in this tweet. And apparently, this story is really bizarre. There is apparently a guy at my gym who takes pictures of guys and sends them out to his Twitter followers and says things about them, okay? And this is the tweet here, okay? I'm going to show it to you. I saved it because I was so flattered. This is the best thing that has ever happened to me in my life, okay? And I'm going to tell you why this is the best thing. Let me show you what it says. He calls me in here Bald Muscle Daddy, okay? And that's the picture of me he snapped secretly, sent it out to his Twitter followers. And then one of those Twitter followers happens to be a friend of my son who made its way to me. This is the coolest thing that has ever happened to me. I think that I'm a pretty fit guy. I take pretty good care of myself, but I am in the big leagues now. Somebody's actually taking creepy pictures of me and sending them out to their Twitter followers. This was so exciting. I posted this on Facebook. One of my students who was following me actually made a little plaque calling me Bald Muscle Daddy. It's in my office. This is the greatest thing. So that is what BMD stood for. Now, out of all the titles I've ever been given, this is my favorite thing I've ever been called. Okay? Anyway, moving on. What's that?
And now it's recorded.
Now it is recorded for all the internet to see. And if any of you received this original tweet, please don't tell me because that's creepy and weird. Okay. So, the question of today was, why do some people hurt more than others? And to understand or to answer this question, I'm going to give you some points of history, some points of Polish history, okay? And you'll understand why this is so important here in a little while. So some points of Polish history that's going to explain why some people hurt more than others. Poland has been around as an ethnicity, or Polish people have been around for an ethnicity for a long time, probably dating back to about the 500 AD is when the language and culture started to emerge on the scene in northeastern Europe. But it really came onto the scene in about 1569 when Poland joined with Lithuania and became the Polish-Lithuanian Commonwealth. That's when it became a really big, powerful nation on the European scene. For about 200 years, it was one of the biggest, wealthiest countries in Europe. And once again, I can't really get into all the details of this in a half-hour lecture. But if you know anything about Polish history, which I'd be surprised if any of you do, Poland started to be carved up in 1772 between Austria, Russia, and Prussia. Austria, Russia, and Prussia just kind of got together and said, you know what, we want part of Poland, and they carved out pieces for themselves. That was called the First Partition. And then in 1793 and 1795, they basically just carved up the rest of Poland. Poland as a nation ceased to exist in 1795, and that was for about 130 years. During that time, those powers, Russia, Austria, and Prussia, they tried to stamp out Polish language and culture. It was actually illegal to speak Polish. It was illegal to write in Polish. All schools you had to learn in German. Everything was taught in German or Russian. So during that time was actually called the Polish Awakening is what they called that during that time. That is when most Polish art, literature, music all flourished during this time. During this part, after the third partition, when Poland ceased to exist, that's when, if you ever read any Polish literature, once again, I don't know why you would, nobody ever reads Polish literature, but if you did, it came from that period of time when it was illegal to write. Actually, Chopin, you guys are familiar with, he composed most of his music during that time. Poland was reestablished as a nation in the Treaty of Versailles in 1918, and that's when Poland, as you are all familiar with it, was reformed, and the borders that you see today were formed in 1918. Then in 1939, the Soviet Union just annexed all of Poland and said, you're part of us. That's when Poland fell under Soviet rule. During Soviet rule, religion and church attendance were heavily discouraged and penalized. You could not have a good job in the government. You were persecuted. The KGB spied on you extra heavy if you were a religious person during that time. The Soviets did not like religious people during that time. So then in the 1960s, Solidaridad, or Solidarity, under Lech Wałęsa, they were a union, basically. I think they were if I remember right, they were a shipping union or something, and they worked in the shipyards, if I remember right, is where they started. And they really were opposed to Soviet rule, and they opposed Soviet rule for decades, and eventually it was largely because of Lech Wałęsa that the Soviet Union's power in Poland finally crumbled. That was in 1989. So the effects of that religious persecution are kind of odd, and this is actually unique worldwide, because Poles actually became more religious during Soviet rule. Attendance skyrocketed. This is no joke. 3,000 churches were built in Poland under Soviet rule. Let me just give you, this map is going to put things in perspective for you. So this is religious attendance in Europe. This is Poland right here. This is Ukraine, this is Belarus, this is Lithuania, Germany, Czech Republic, Slovakia. 61% of Poles still, to this day, attend church at least monthly. And you compare that to all the other nations around, and you can see that Poland's church attendance did not wane during that time. And this is another graph to put things in perspective. Sorry the writing is so small, I should have cut it off and expanded it. This is weekly religious attendance in the United States and Europe. Poland has 44%. The previous map was monthly church attendance. This is weekly church attendance, so the numbers look a little bit different. Excuse me. Poland has 44% weekly church attendance. Okay, putting that in perspective, Utah, which has the highest church attendance in the United States, is 41%. Okay, so, and you can keep going down if you're ever curious. You can see clear down at the bottom is Denmark. They get 3% church attendance. Slovakia has 34%, which is right next door to Poland. Anyway, so just to kind of once again contrast that, if you look at Germany, this yellow line right here is the border between East and West Germany. So this was Germany under Soviet rule. This was Germany not under Soviet rule. The contrast doesn't show up here, but what this shows, if you look at the graph, about 70 to 80% of East Germany is atheist. Okay, so this is a map of atheism. This is still people who attend church regularly. They consider themselves religious. Still about 70 to 80% religious in the rest of either Catholic or Protestant in the rest of Germany. So clearly in Germany under Soviet rule, when the Soviets discouraged church attendance. Church attendance plummeted and religiosity plummeted in Germany. The exact opposite of what happened in Poland. So, having said all that and setting the stage, I want to present to you 3 patients, okay? Let's talk about these 3 patients. The first one is a 37-year-old male with 1 week of excruciating pain on the neck on the right. It's radiating down the right arm. And he shows up in clinic with 1 day of weakness in that arm, in the the right triceps and pectoralis. Okay, let's talk about another guy who shows up. This is a 21-year-old guy, otherwise healthy. Just showed up with 1 week of severe lower back pain, worse in the parasitical area, radiating up the back. He injured at work when he was thrown against a railing. Somebody tossed a heavy box to him. He was thrown back against a railing. And he has been having now severe lower back pain for a week. We have another case who shows up about a week after about a week of low back pain. And she has 3 weeks of generalized middle and lower back pain. She was in a car accident where she was a restrained driver and stuck on the passenger side of the car. So with these 3 patients, if you just had this much information, which one would you assume or guess? If you just had to make a guess, who would you think in 1, 5, 10 years is going to have the most pain? Or would you have enough information to make an educated guess about this? Any thoughts real quick?
21-year-old.
You're thinking the 21-year-old is going to have the most pain. I'm just curious why you think that.
Often getting injured at work has some complicating factors in terms of having workers' comp, returning to work, enjoying their job.
Sure, that's actually a great analysis. Any other thoughts? Okay, yeah, and actually that's that injury at work is a big predictor of ongoing or chronic pain. Absolutely. I am curious though. So the 37-year-old male, nobody said him, even though he actually has pain radiating into his arm and he has weakness in his arm, but nobody thought or nobody said out loud that it would be the 37-year-old male. So let's talk about some predictors. And these are all things that have been studied off and on. There are dozens and dozens of studies, probably hundreds of studies out there about ways you can predict or how you can predict who's going to be in pain long term after some kind of an accident. Number 1, radiological findings. How good a predictor is that of ongoing pain? Any thoughts? Does anybody know the data about that? We'll get into it in a minute, but does anybody know offhand? Yes.
In my practice, when somebody has severe spinal stenosis and their symptoms correlate closely with what we see on the imaging, they tend to do very well. On the 37-year-old, if you showed an MRI showing a disc herniation in his neck, pinching the nerve that goes down that right arm, and that's a fairly treatable problem versus somebody that, say, sprained their lower back in a work accident without a readily treatable radiographic issue.
Absolutely. We're going to get, yeah, that's actually great. That's exactly correct. So radiological findings. How about physical exam findings? Are there any physical exam findings that would predict, like when you see somebody in clinic and you're doing a physical exam, any thoughts about that where this physical exam finding or presentation would make you think this person's going to be in pain for a long time or disabled? Yes.
Maybe the total body dolor. When you go to like anywhere you touch, they're like, oh, like that for me. You know exactly what I meant, though.
Yeah.
So I don't know if that would.
Yeah. Yeah, that's great. I'm sorry?
Symptom magnification.
Oh yeah, circumnagnification. Yes. Symptom magnification. Yes, absolutely. How about family history? Does family history predict, like my dad had back pain, now I have back pain, or my, back pain, arthritis runs in my family? Any thoughts? Does anybody know offhand? Steve?
I think that there could be a psychological component to that sometimes. They're always like, oh, my family had that, so that's always in the back of their mind that they're worried about that. And back on that 29-year-old that you had on there, one thing I thought was it was kind of a PTSD trauma type of a thing for her, which can kind of make that pain a little bit worse as they're healing and as they're trying to go through it, because now we're dealing with two different treatment modalities.
Absolutely. Yeah, that's really sharp. Yeah. How about socioeconomic status? Do wealthier people or people who are highly educated, do they do better after an accident than people who are low socioeconomic status? Is there actually data? I mean, you kind of think reflexively there probably is, but has anybody ever actually seen any data about that? So the answer is yes, there is actually a difference in outcomes based on socioeconomic status. It isn't quite as stark as you might think, but yes, there is a difference based on socioeconomic status. Wealthier, more educated people tend to do better and recover faster and more completely from injuries than people of lower SES. How about mental health? People with a history of depression, right? Once again, we sense this when we talk to people or when we interact with people. And certainly people who have a lot of chronic pain have higher rates of depression, but which one is actually the cause and which is the result, right? Am I depressed because I have chronic pain, or do I have chronic pain because I'm depressed? Does anybody know the answer to that? Have you ever seen any studies about it? Once again, there are actually, so Dr. Pitts?
One study that really emphasizes the treatment of depression and anxiety. If they are not currently treated according to DSM criteria, they are 5 times more likely to have a bad outcome with a total joint.
Yeah.
So just by having that diagnosis, at least for the orthopedic joint surgeon, the first goal should be, how is your depression, how's your anxiety, is it well treated, and can we maximize that treatment prior to joint replacement? Otherwise, you're basically setting them up for a bad outcome. Even though the surgery may be great, that whole perception of pain may be the main issue.
I'm just curious, is that actually a standard guideline? Like if somebody comes in with untreated depression, they need to have the depression addressed before surgery?
Yes, American Association of Hip and Knee Surgeons actually has a clinical practice guidelines that talks about management of that in order to have the outcomes be better. So there's kind of 6 criteria they look at, but the 2 main ones they really focus on are depression and anxiety.
That's interesting. I didn't know that.
In the pain column too, when you have to do a stimulator therapy for a patient,
Mm-hmm.
the insurance requires that you have to undergo psychological evaluation to make sure that the patient doesn't have untreated depression or.
Really?
Yeah.
Oh.
Yeah, it's cool.
I didn't know that either. That's really cool. So, how about history of trauma? History of emotional trauma of some kind, for example. Does that also results in worse outcomes, right? That's going to be a predictor of chronic pain, probably. How about a history of abuse? Yeah, absolutely, no question about it. Depression, we just talked about. How about locus of control? How many people know what locus of control is? Does anybody know? Has anybody heard that term before?
I
Yes.
think it's like internal, external locus of control. So internal is like, hey, it's up to me. Whatever I do will, affect things. External locus of control is like, it's in the stars. Right? There's that famous Shakespeare line that it's not in the stars, it's in us, right?
Yeah.
And so I think that highlights the internal and external locus of control.
That's exactly right. There's an official definition that I'll give you here in a second. So, locus of control, that is exactly right. Is this something that is the world, my interaction or my fate, is this something determined by me, or is it determined entirely by outside factors? Okay, that's locus of control. So there are two things that I'm going to cover here real quickly to contrast when we're talking about patient outcomes in chronic pain. I'm going to be talking about radiological findings, and I'm going to be talking about locus of control. So going back to these people that we were just talking about, the 37-year-old male, and this is going to what Dr. Edwards was just saying here, the MRI of his cervical spine shows large right-sided herniation at C6 and C7 with compression of C7 on the right. So he actually showed up to clinic with complete loss of strength in the right pectoralis and right triceps, complete loss. He had no strength at all. He gets this MRI, it shows huge herniation, compression of C6 and 7, and according to Dr. Edwards, he, out of these 3, probably has the best likelihood of outcome. okay? Specifically because there's something you can point to and say, this is the problem, this is why you hurt, we can do something about it, okay? So the 27-year-old male, the MRI of his lumbar spine shows a small left-sided bulge at L5-S1, no foraminal stenosis or nerve compression. So having seen that, and going back to, sorry, who said it over here about the work injury? Yeah, so work injury, nothing really obvious here. Obviously, if his family medicine doctor comes to him and says, you've got this bulge at L5-S1, this is going to stick with him for the rest of his life. He's going to tell everybody he ever talks to about his back pain, I have a bulging disc and that's why I have pain in my back. It drives me nuts. Every person who comes into my clinic with back pain says, I got a slip disc and that's why I hurt. And I grind my teeth and I say, who told you? Anyway, we all know this. This drives us all crazy. What's that? Yes. That's right, yeah. Yeah, and when I send them to physical therapy, they're like, okay, is the disc bulge going to go away? And I'm like, no, your disc bulge is not going to go away. Anyway, so the 29-year-old female, she has nothing at all. Her MRI is completely normal. She is totally fine. Totally fine as far as physical findings on MRI. And so if we were once again going to make a prediction based solely on radiological findings, we would say, according to Dr. Edwards, that the one most likely to, just based on that, if that's all we have to go on, the one with the herniated disc is probably going to do the best. So let's talk about some of the studies about radiological findings and pain. So according to, it would be in 2021, I have all the, if you're curious, you can see all these studies at the end. Disc degeneration and facet joint degeneration were not associated with long-term disability. Baseline modic changes and weekly physical activity at leisure were statistically significantly associated with less long-term disability. Basically, disc degeneration, facet joint degeneration does not predict. You can't tell me that if I get an MRI showing degenerative disc disease, that is not associated with long-term disability, okay, or long-term chronic pain. I am curious, though. They actually said, though, modic changes were associated with less long-term disability. Does anybody know why that would be? I didn't follow that rabbit hole. I found this on a study, but I didn't follow up on that. Does anybody know why that would be? Why modic changes would actually be associated with less? I mean, I can take guesses, but I don't want to just make guesses about this. Anybody have any thoughts? We'll just move on. Okay. Another study. The findings of magnetic resonance scans were not predictive of the development of duration of low back pain. Individuals with the longest duration of low back pain did not have the greatest degree of anatomical abnormality on the original 1989 scan. So this was a study where they basically just took a whole bunch of people. They did not have a lot of pain for the most part. I think they might have had a little bit of intermittent back pain, and they just did MRIs on everybody's backs. I don't remember how many people were in the study, and then they followed them for something like 15 years to see who would develop back pain or maintain or keep having back pain after 15 years. And what they showed was, based on these MRIs done back in 1989, they could not predict who was going to have, there is no correlation between radiological findings and development or resolution of back pain. Okay. So another study. The development of serious low back pain disability in a cohort of subjects with both structural and psychosocial risk factors was strongly predicted by baseline psychosocial variables, which is what we said on that previous slide. Psychosocial variables was a strong predictor. Structural variables on both MRI and discography testing at baseline had only weak association with back pain episodes and no association with disability or future medical care. Okay. These are just 3 studies. There are hundreds of studies like this. When I was just doing a search on PubMed, there are about 100 studies that show exactly the same thing. And it's the same thing we said on that previous slide. There is very little or no correlation between what you see on MRI and whether somebody is going to have back pain in the future. Okay? So, let's talk about locus of control. And Dr. Edwards answered exactly correctly. Locus of control is the degree to which people believe that they, as opposed to external forces beyond their influence, have control over the outcome or events in their lives. Locus of control. So does that actually have a big impact? How big is that impact? And just before I go on, I could have chosen, when I gave those lists of all the potential predictors of chronic back pain, chronic disability, I could have chosen any one of those: socioeconomic status, depression, history of trauma. I could have talked about adverse childhood experiences, which I didn't talk about. But I could have chosen any one of those, and there's a specific reason I'm talking about locus of control today. So locus of control, how big of an impact does that have? Zerker Hurleman says internal locus of high locus of control showed predictive value regarding the reduction of pain intensity in a multidisciplinary inpatient treatment for chronic pain, whereas social external and fatalistic external high locus of control did not. That is, if you have a high internal locus of control, you do much better than if you have an external locus of control. Okay, pretty straightforward. It seems pretty obvious. So let's talk about ethnicity then. You'll see why right here, why I started out with a story about Poland. So in 1992, there was a study done in New England where they actually studied different ethnicities and their response to a pain management course. Okay, and they correlated ethnicity, locus of control, and improvements in pain outcomes. And you will notice, first off, so the different ethnicities, Old American, that means you consider yourself an American. That's what that means. You don't consider yourself Italian American, Polish American, whatever. Hispanic, Italian, French Canadian, Irish, and Polish. Look at the Polish graph. This is a graph of internal versus external locus of control, okay? So the shaded area right there, that is external locus of control, okay? Black is internal locus of control. So Hispanics have very high external locus of control, very low internal. Look at the Polish internal versus external locus of control. They are almost entirely internal locus of control. So based on that graph, you would predict that, then, based on what we've been talking about, based on that previous slide where we said that internal locus of control is a predictor of good outcomes, that then the Polish people would have the best outcomes, and that is in fact exactly what you see. So this is the summary from that study. Analysis showed that the most frequent, et cetera, down at the bottom, either the Polish or, so I'll just read the whole thing. The ethnic pattern is consistent. The Hispanic group has the highest intensity mean, the greatest interference with work and social activities, the highest degree of emotional and psychological stress, and the highest pain expressiveness. The Italian group is second highest in each of these categories, and either the Polish or the Old American group is lowest in each category. So what this study showed was that yes, my ethnicity, the culture that I grew up in, the culture that has given me all my early childhood development experiences with locus of control, actually does not only predict your locus of control, but it actually predicts pretty closely how you're going to do after an accident in the development and recovery from chronic pain. Okay, so I know what you're all thinking, or more to the point, I know what you should be thinking, which is, but Bald Muscle Daddy, could this be actually generalizable? Is this actually a useful study? We are not in New England. This study was done in 1992. So what kind of people are the Polish immigrants that they're studying? Those are all refugees from Soviet Russia. These are people who spent their entire life resisting Soviet rule. Okay, that's why they have such high locus of control. We don't have a diaspora of Polish people here in Utah, or not a very big one. The biggest diaspora of Polish people that I know of personally is my wife. Okay, my wife is Polish, and when I stumbled onto this article, I was actually not looking for a study about Poland and locus of control, but I found this and I showed it to her. She got so excited, and she had to tell her mom about this. Who was a refugee from Soviet Russia. Actually, my wife too. My wife came to the United States in 1985 as a refugee from Soviet controlled Poland. My mother-in-law and father-in-law came at the same time, so they would be in this group. Okay, we actually had a Polish foreign exchange student living with us last year. She's a teenager. She does not think anything at all of Poland. She thinks it's a backwards, a provincial little European country. It's nothing interesting. Her whole life goal as a Polish teenager is to move somewhere besides Poland. Okay. So once again, the question is this study right here generalizable? This study where we showed that Polish people have higher locus of control, internal, and better outcomes versus Hispanic people? The answer is no. The point of this study, and the point of me bringing it up, is not to say that if a Polish person walks into your clinic, you can predict that they are going to have a better outcome. The point of this study is to illustrate the connection between culture and the way we are raised and the way we are taught about how we interact with the world and our outcomes as patients. Okay. There are actually a lot of different studies about locus of control. For example, all things being equal, conservatives tend to have higher internal locus of control than liberals do, for example. There are studies about different religious groups. I couldn't find one specifically about Latter-day Saints or Catholics, but there are a handful of studies out there if you're curious about locus of control in different cultures that generate different levels of internal versus external locus of control. The point of all of this, though, is that what drives recovery from chronic pain. Actually, let me back up real quick. So the two just real quick samplings of studies I showed you. One was about radiological findings, and then the other one was about locus of control and ethnicity. The reason I chose those was because an MRI or MRIs and X-rays is the closest thing we have to an objective measure of physical derangement of spine or joints. Okay, that's the closest thing we have. Okay, and if physical derangement or physical pathology does not predict chronic pain has to come from somewhere else then. Either that or we are looking at it with the wrong objective tools. Okay, and so chronic pain and disability then have to come from somewhere else. It does not come from those physical things that we see on MRI. It comes from something else. And this is one example of that, and one pretty striking example of the stories we tell about our pain. Just to kind of summarize, those are the studies if you're curious. But once again, those are just a sampling. There are 100 studies out there about all of these things. Those 3 patients that I told you about, there's a 37-year-old male. That was actually me. I injured my neck on I was just doing a little army exercise. We were just carrying some heavy things around. The next day I developed pain in my neck, radiated down into my arm. 5 days later, all of a sudden I went to get out of bed, and I could not lift myself out of bed with my right arm. My arm was completely gone. And over the next few months, my right pectoralis and triceps completely vanished. They were basically gone. And exactly what Dr. Edwards said when I saw a neurosurgeon about it, he said, "It'll just get better, don't worry about it." And I was like, don't worry about it? What kind of a lame thing to say is that to a guy with a paralyzed arm? And it did. I'm fine now, it doesn't bother me. The guy who, yeah, lame but true, yeah. The guy who injured his back at work, just like you predicted, he is still in excruciating pain all the time. Every time I see him, he's doing worse. He is now on cannabis. He is now on disability. He has severe depression. And going back to those other predictors about his life, he has a long history of severe trauma as a child. Very abusive household, very low socioeconomic status. And he is doing very poorly. The young lady actually is the most interesting one of those 3. She was in that car accident. When I saw her, she was on something like 240 Percocets a month. In addition, somebody else was giving her some other kind of pain control on top of that. And she actually decided one day that she was tired of opiates, and she, no joke, she locked herself in her room for like 2 weeks and just went off on her own, went off all of her opiates. She went through severe withdrawals, and I didn't see her, I didn't know any of this. She didn't ask me about that. She went through, I saw her a couple months later, and she's like, you know, I'm off the opiates, I am in a lot of pain, but my life is like 1,000 times better now. So anyway, point here is the stories we tell. Final question, though, that you should be asking is, so then can we change, as clinicians, can we change locus of control? The short answer is yes. The long answer is maybe a little bit. With a lot of intense therapy and a lot of time, people can change that locus of control. It is not something that you or I do in a single inspirational speech to patients, but it is something to consider. Any questions or any thoughts about that? I know I kind of rushed through a lot of that. Yeah?
Yeah, is there a question that you ask patients to determine as like a yellow flag question?
They will usually tell me in the way they describe the accident. For example, the guy who hurt his back, every part of that discussion when he was telling me what happened was something happened to me. He'll tell you right up front, someone threw this box at me, it hit me, I was thrown back against the wall, and then my work sent me, it was all of this stuff happened to me. And I mean, I guess I could use my own, whenever I used to tell the story about my injury in my neck, I would always say I was really working hard, I was lifting this thing, and then I was running around doing this training exercise, and I was working out really hard, and then I injured my neck. I mean, that's the kind of contrast you see in the people. The young lady who was in the car accident, she was actually kind of between the two, although every time I talked to her, she was always talking about what do you want me to do to get better? That was how she always approached that. Whenever she came into clinic, she's like, I hate being on these opiates, what can I do? And I'd be like, all right, well, let's start weaning down, we'll get you into physical therapy. And she was always compliant, but it never worked. Nothing she did really seemed to improve the pain, probably because she had been on opiates, very high dose opiates, for a long time. Any other thoughts or questions? Okay, we'll wrap it up there. Oh, sorry,
I do. I had to undergo a training to be able to treat patients from the VA. Mm-hmm. And that was showing us the difference between treating civilians versus patients who serve in the military. And it seems like from the training, one of the takeaway points is that civilian population has the higher external locus of control versus when you treat somebody who has served, you treat them a little differently because they have a higher internal locus of control. Mm-hmm. What do you think is a point where a lot of people who are in the military have that higher locus of control? How does that come about in the training?
That's actually really interesting, because in the military, I actually spent time with what's called the Warrior Transition Unit, the WTU, which is people who have been injured and have to get out of the military because they are no longer, because they have injuries or something. That's a really good question, because you actually see a pretty stark contrast between people who really feel like they're victims of the military, and you see people all the time, you see people in the military who feel like they are always victims, okay? I had bad leadership, I was injured and that nobody took care of me and nobody did these things for me what they were supposed to. I got these bad assignments, I had bad leadership. And then you see a very stark contrast between them and the people who are saying, I got into the military, it's been hard, it's been rough, and I loved it, and I overcame all these things. The outcomes. One of the reasons why I was interested in this, I didn't know anything about locus of control until I started studying this a couple years ago, but it all fell into place. I don't know why some people in the military respond very negatively and why some people respond very, very positively. A lot of the veterans that I treat in my clinic, when I talk about their military career, they're really proud of it. It was like the greatest thing they ever did. They wear their little, veteran hats, and they And they think the military was the greatest thing that ever happened to them. And then you meet some people who say, you know, I got into the military and I got screwed from day one, and then I got hurt and they kicked me out. And that's kind of how they tell their story. Yeah.
And that may be related more back to the cultural, socioeconomic issues and so on, that those people that before they go into the military, and so we have an overlap there.
It may be. And actually, older military, and this is a really long discussion. We probably don't have time for this. It's already quarter to 8, but you actually see a big difference in older military people who served back in Vietnam and back in the 60s and 70s, who the military was a lot more brutal emotionally and physically back then. They were allowed to really demean and brutalize people in basic training and throughout their careers. Those people actually speak very fondly of their days in the military for the most part, whereas today, where you have to be really careful about not insulting people or not hurting their feelings so much. And I'm not, once again, this is a long discussion, and I'm not necessarily criticizing the military's decision making, but you actually see a big difference between those people who served back in the 60s and those in 70s and the people now who, for lack of a better word, tend to be more fragile, I guess. Coddled, maybe. I'm not, once again, long discussion. I'm not going to say one way is better than the other, because there are lots of things that go into that, but that's maybe part of why older veterans, at least, have a very different view on their military service than younger people, maybe.
I just thought if there's part of training that can be, brought over into the medical side.
And we can shout at our patients, swear at them. Yeah, yeah. I think that'd be healthy for some of them. I don't know. Any other thoughts? Sorry, I know I kept you guys longer than I had meant to.
I know we're running late. Oh, go ahead.
Just a quick comment. I love that you started on the religious side of this, just by showing how many people in Poland go to church. My daughter just got home from the Czech Republic, which is the country just below, and she would often go into Poland, and she loved that because the whole country of the Czech Republic is one state. And you go into Poland, and they're much more religious and open to religion, whatever religion that may be. And I wonder if that correlates to this internal number that you're showing.
It probably does. I could not. There are a couple of studies about religion and locus of control, and I glanced at them. But yeah, if you're curious, there are some great studies out there. It's actually really fascinating, the different cultures and their relation to locus of control.
I was just going to comment, I worked with a gynecologist, and she would pay to have her patients, if they were willing, to do some therapy before each surgery. So she'd pay $150, $200, and they would have 4 sessions of meditation. She would have them listen to this tape, and they would do this mantra, I'm going to do well, I'm not going to be in pain. And they would repeat that as they're going into the surgery, and all of her colleagues thought she was crazy. You're paying out of your own pocket $150, $200 each surgery. Isn't that cutting into your profit? And she said, I get fewer calls. My patients aren't on opiates as long. They come back, I have better scores, satisfaction, well worth the money. And so I thought maybe that's one way to increase that internal, or at least help them develop it.
Yeah, it's a good start, absolutely. So I think we really have to go, though. It's pretty late, so.